I have the pleasure of introducing our presenter. Her name is Dr. Daniela Chiriboga-Salazar. She's a senior physician for the Florida Department of Health. Dr. Chiriboga was born in Quito, Ecuador, graduated as a doctor in medicine and surgery at the Universidad San Francisco de Quito in Ecuador, completed residency training at the University of South Florida in internal medicine and pediatrics, as well as a specialty in infectious disease, becoming board certified in all three specialties. He is the director of Communicable disease for the Florida Department of Health in Polk County, as well as the medical director for the Florida Department of Health in Hardee County. Her practice is divided between the specialty care clinic for HIV and general pediatrics for the Department of Health. Dr. Chiriboga follows pregnant HIV-positive women throughout their pregnancy and their HIV-exposed children at the specialty care clinic, which is located in Bartow, Florida. She is passionate about prevention of mother-to-child transmission for HIV, and she is also a mother of a 4-year-old and a 7-month-old, both boys. And we welcome you this morning, Dr. Chiriboga.
Thank you, Millie. First, let me say that I do not have any conflict of interest to disclose. So let me go ahead and start. And so today we're going to talk about something that we have achieved at the Florida Department of Health in Polk County, which is trying to combine the care of the pregnant woman and her infant so that it becomes sort of a family-centered approach. And we have been able to do that thanks to the fact that we have an interesting setup here that I will talk to you about in a minute. So here are your objectives. Upon the completion of this program, you'll be able to describe the elements of care for HIV-positive pregnant women and their infants according to the guidelines. You will be able to describe the Florida law and guidelines concerning HIV testing during pregnancy, rapid screening in labor and delivery, and postpartum testing of HIV-exposed infants. You will be able to list possible barriers to care and strategies that can be implemented to overcome some of these challenges. And you may be able to state ways to increase coordination of care for these patients with other entities within the local health department. I have put up this slide here that a lot of you know very well, showing the map of Florida with all the HIV-infected newborns. And the idea was for you to be able to find where Polk County is. So as you can see, Polk County is right here in the middle of the state, right between Hillsborough County and the Orlando area. And we are the second largest county geographically in the state and about the 6th when it comes to population. In a year, we have somewhere between 15 and 20 pregnant women that are followed through the health department, and we do also take care of the perinatal coordination for Highlands and Hardee County, which are two of our neighboring counties. There's a little bit of a discordance between our data and that belongs to the AETC. As you can see, we have 2 infected infants reported in our data, and the AETC only gives us one little dot on this map, and that is because one of the children was actually born in Polk but belongs to Pinellas when it comes to reporting. As I said, the program that we have has been a little bit on the unique side, thanks to a coincidence of some things that have happened historically. Our program started in 2005, and initially we had a perinatal coordinator who was actually Millie Leach, that a lot of you know, and she coordinated the care of the pregnant women at the clinic. But she also had to refer the children to be cared for at All Children's, either in St. Pete or Tampa, or an infectious disease doctor would travel from those sites to Polk County for caring of the exposed infants. And because they were only able to travel every other month, that would lead to some difficulties with transportation for the mothers and some difficulties with coordinating their care. So in 2008, to minimize that, we started a clinic for exposed babies within the health department, which slowly evolved towards a mother-baby clinic. We realized that it was easier for the mothers to come in with their children at the same time, and we started evolving this clinic. Now, unfortunately, over time, we've had a humongous changeover of perinatal coordinators. After Millie left, I'd say we've had about 4 perinatal coordinators in the last 2 years, and we've been very lucky, very blessed to get our most current one, Whitney Albert. But I think the only reason we've been able to survive this humongous changeover has been thanks to the fact that we had such a systematic program, and also that most of the services were being provided on site, and that way we could keep control without needing a lot of coordination of efforts. So what's our team? Our team is made up by myself. I am an HIV physician. I am trained in internal medicine and pediatrics, and I have a subspecialty in adult infectious disease. I do not have a subspecialty in pediatric infectious disease, but I am a pediatrician. That allows me to be able to care for HIV-positive women and their exposed but not HIV-positive children. I do not follow HIV-positive children. I refer them to all children. We also have 2 nurse practitioners at our clinic who have specialized in caring for HIV-positive adults and occasionally will help with the children if I am not able to be present. We have our perinatal coordinator, who, as I said, is Whitney Albert. Whitney is not a nurse, but she has gained enormous knowledge over the years, and her role is more on the case management side. We have one of our clinic LPNs who has specialized also in caring for exposed infants and the pregnant women. We are right next door to the health department's high-risk OB clinic. It takes me about 30 seconds to cross from my office to Dr. Paredes' office. They have 2 obstetricians. They have a nursing supervisor who is the one in charge for monitoring all the HIV-positive pregnant women. We also are very lucky that within our same building we house the disease intervention specialists and surveillance for the health department. So I can walk over to DIF and ask them a question or ask them to find a woman who is not following up. And the surveillance can also give us information regarding if children have been tested and so on very easily. Our clinic houses case management. We house our own Part B case managers. And we also, our health department still manages Healthy Start and Strong Start, and they are part of our team in caring for exposed babies and their mothers. Our perinatal coordinator is in charge of coordinating the care. I like how that sounds. It's very redundant, but she is in charge of coordinating the care between the sites. Most HIV care for our patients is received at specialty care clinic, although there are about 3 private HIV providers in the area, 2 in Polk County and 1 in Highlands County, who do sometimes follow their own pregnant women throughout pregnancy. On the same side, most OB care is received at the Department of Health high-risk OB clinic, although we are seeing more women with private insurance who are not able to be followed at the health department and are being followed by their own private obstetricians. And obviously with these patients who are outside the system, Whitney makes sure that she coordinates with both providers and also tracks their lab results and helps with coordinating with the hospitals. As I said, we do have case managers on site, and we have one specific case manager who will be in charge of all the pregnant women. Every single pregnant woman who goes through our clinic is case managed as long as she qualifies for Ryan White. The DIS workers also assist us. They're even able to provide transportation for women who are not able to assist their appointments. So that helps us get people in and helps us also reach out to women who may not have phone numbers. Their phones may be disconnected, maybe choosing not to answer our phone calls or our letters, etc. DIS will go out to them and track them down. We have a monthly interdisciplinary meeting, which is attended by all parts of this system. And during those interdisciplinary meetings, we discuss each patient, each pregnant woman, and then we discuss each child younger than 4 months old who's being followed, or any child who hasn't completed their testing. and we decide on the course of action, be it we need to send them another letter, DIS needs to go out and find them, or everything is going well, we just need to do testing at such time, or etc. So what are the advantages of this approach? The biggest advantage is that it's easier to coordinate the appointments. When we first developed this program, our biggest goal was to coordinate appointments easily, and therefore we were hoping that it would be easier to keep moms in care. And you will see towards the end of my conference that we haven't been as successful at doing this as we thought we would be. Also, because we know these patients most of the time before they get pregnant, we can provide better preconceptional care. By bringing the mother and the child in at the same time, we find that there's less transportation difficulties. Our state is extremely large, and to get here by bus can take you the whole day. Sorry, I said our state. Our county is extremely large, and for example, to get here from Davenport could really take the whole day to arrive to the Bartow Clinic. The other advantage is that the HIV physician is the same for the mother before pregnancy, if she was already known to be HIV positive before the pregnancy, during the pregnancy, and after the pregnancy. And also the same physician will be following the baby. So I already know the baby's history, the mother's history, before I see the baby. This allows us to make decisions regarding testing, if baby needs to be tested sooner, if we want to ask the hospital to do testing before they send the baby out, etc. It also allows us to provide a lot of education on the baby's care during the pregnancy, and I'll talk about that in one of my future slides. So I'm going to present to you a case, and all these cases are taken from real patients that we have followed over time. Mrs. A is a 20-year-old female who acquired HIV vertically. She has been followed by our clinic since she was 17. She's on a stable HIV regimen of atazanavir boosted by ritonavir with tenofovir and emtricitabine, so Norvir, Rayataz, and Truvada for those who like commercial names and it's easier in your head to hear these. And her viral load has been undetectable since she started at our clinic. Her last CD4 count was 620. She had been followed by all children's before she came here, and her viral load had been undetectable for years even before then. She now thinks that she is pregnant and would come into the clinic for a pregnancy test. And sorry, I should have clarified this before I started on the cases. We're going to have 3 cases that are running concomitantly. To avoid confusing you, I have made the slides different colors. So you will see Mrs. A will be pink, the second patient, Mrs. B, will be purple, and our third patient, Mrs. C, will be blue. I hope I don't confuse you by having 3 patients running at the same time. So our second patient that we're going to follow today is Mrs. B. She's a 36-year-old Hispanic female. This is her 6th pregnancy. And she came into the health department's women's health clinic for management of what she thought was a healthy pregnancy. And she decided to refuse HIV testing. She didn't see any reason to have it done. The midwife, we were very blessed that we have a wonderful midwife who decided to insist a little bit and convinced her of allowing HIV testing. So she finally had an HIV test in the mid-2nd trimester, and this was positive. Our third patient, Mrs. C, is someone who's very well known to us. She's 30 years old. It's her 4th pregnancy, and we have been following her throughout her other 3 pregnancies. Her other 3 children are not in her care. She has a strong history of substance abuse. She's been HIV positive since 2003, and she has not been adherent with care. She has multiple resistant mutations, and her last CD4 count in 2012 was 54. Her viral load was about 850, and this was because we had managed to get her on medication towards the end of her pregnancy. So how do we care for these pregnant women? Our model shows that we either receive women such as Mrs. A and Mrs. C who are already in our care, or at least who are known to us. And then we also had patients who are referred to us because they have positive tests, such as patient B. Either they're tested outside in the private system, or they are tested by the health department, since we also do provide women's health and pregnancy care. The HIV provider who is assigned to them manages their antiretrovirals. I think this is different from other sites where the OBGYN manages their antiretrovirals during pregnancy. The OBGYN manages only their gynecological and obstetric aspects, and the perinatal coordinator walks between the two clinics coordinating their care. The advantage, as I said, is it takes them about 1 minute to be in the other clinic. Case management and DIS are involved with all of this care, making sure that the woman's insurance needs, housing needs, social needs are met, but also making sure that we can get the woman into care and keep her in care. Some of our patients, like patient C, are a little harder to keep in care than others. Our goal is to make this a one-stop shop. To be a little more explicit, we also have a mental health counselor who is at our clinic. We have a dietitian who is at our clinic, and all these services are available for pregnant women. Dental is available through the health department about a block away from us. So going back to Mrs. A, so we do a pregnancy test on her, and she definitely is pregnant. Her last menstrual period was about 8 weeks prior. Since she is a vertical transmission, she is very concerned about how to protect her baby from vertical transmission, and she wants to know what the risk is that her baby would be HIV positive. If a woman is not identified and treated, the risk that she would transmit HIV to her unborn child is between 25 and 35%, depending on which literature you read. In the absence of breastfeeding, most of that transmission, 70%, occurs during delivery. Therefore, our main goal of treating HIV-positive pregnant women is getting their viral load as low as possible for the time of delivery. There's also an additional risk that occurs with breastfeeding that varies around 20% if a woman has established infection. Now, there's some new data that shows that if a woman's viral load is undetectable, the risk is still about 1 to 5%, and that was published in the new guidelines that just came out about 2 weeks ago. So our main goal is obviously to start antiretroviral therapy as soon as possible, and the goals of antiretroviral therapy are to suppress the HIV viral load. By doing this, we decrease the risk of transmission to the infant. We decrease the risk of transmission to sexual partners. Obviously, if this woman got pregnant, she is having unprotected sex, unless there was another way of pregnancy, and we'll talk about that in a minute. We also want to seek to improve maternal health and immune status of the mother, and we want to decrease the risk of development of resistance, both because we want to decrease the mother's risk of resistance as well as decreasing the risk of resistance in the infant if the infant were to be infected. Now, the new guidelines have a little bit more guidance on use of antiretrovirals in pregnancy, but mostly women who are already on antiretrovirals should continue their current regimen. Now, the note on efavirenz is that even though it's pregnancy class D drug, the newest guidelines recommend that efavirenz be the first-line non-nucleoside regimen as long as it's started after 8 weeks. My personal bias on efavirenz is that if we can completely avoid the use in women of childbearing age, we're better off. If someone needs to be put on it after the first 8 weeks of pregnancy for some reason, that is based on the guidelines and that is acceptable. But if we can avoid using it prior to pregnancy, we will make a big difference in children's outcomes. I have seen a few women who have gotten pregnant on efavirenz, and again, this is my personal opinion. I think that at least the risk of miscarriage is increased, and the woman's anxiety once they start reading that this is a pregnancy class D drug increases significantly, and I think it's best to avoid using efavirenz if possible. But we also know that the current guidelines say that it is safe to continue efavirenz in pregnancy and preferably avoid the first 8 weeks. So if there is a woman who is on efavirenz at the time of pregnancy, she does not need to be counseled on terminating the pregnancy, especially because, as I said, this does increase anxiety significantly for a lot of women when they find out that they are on a pregnancy class D drug. So our Mrs. A was already on boosted atazanavir with tenofovir and emtricitabine. So we decided to keep her on this drug. These drugs have a lot of evidence for pregnancy. We did discuss that she would have to increase her atazanavir dose to 400 milligrams at 20 weeks. So you maintain the ritonavir, it's still boosted, but you go up to 400 milligrams of atazanavir at 20 weeks of pregnancy and continue it until the baby is delivered. We obtained her initial appointment at high-risk OB. Since this is influenza season, we gave her an influenza vaccine. We had already given her an influenza vaccine prior to the pregnancy. That's common practice in our clinic. And we will be giving her a Tdap, that's a tetanus, diphtheria, and a pertussis vaccine in the 3rd trimester. We do TB testing on all our patients annually and make sure that we get TB testing on pregnant women at their first visit. So we did a quantiferon gold test, and we conducted education regarding perinatal transmission, sort of what I gave to you a couple slides back regarding what the risk of transmission is if she is on medication and is not. So now let's go to our second patient. Mrs. B was our newly diagnosed woman who's pregnant with her 5th child. She had been very reluctant to be tested, and she is very reluctant to access care for her HIV. All interactions with her are focused on how she could have acquired HIV. She seems to be a little bit in denial. At her first visit with us, she's already 27 weeks pregnant, and we got her to see high-risk OB at the same time. Her CD4 count is 330, and her viral load is 5,200. So this goes back to the guidelines regarding women who are antiretroviral naive. The guidelines recommend that a potent antiretroviral regimen should be initiated. Initiation can be delayed until 12 to 14 weeks of pregnancy, and this depends on risk and benefit. If the woman's viral load is extremely high, or if her CD4 count is below 200, it is best to start medicine sooner than 12 weeks, but discussion should be had with the woman regarding the risks and the benefits. Any therapy that's started in a pregnant woman who's antiretroviral naive should involve 2 NRTIs. And the current guidelines say that we can use AZT with lamivudine, or we can use abacavir and lamivudine, or tenofovir and emtricitabine. All 3 of these are appropriate dual NRTI combinations to be used in pregnancy. If at all possible, a genotype should be obtained. So this applies to all women whose viral loads are above 1,000. You should be able to get a genotype on them at the initiation of pregnancy or at the first visit when they're pregnant. And the preferred choices for pregnancy are ritonavir, atazanavir, and one of the NRTI combinations, or boosted lopinavir, Kaletra, with either with one of the NRTI combinations. So Mrs. B has no resistance on her genotype. We also decided to start her on boosted atazanavir and Truvada, tenofovir and emtricitabine. She is already past 20 weeks, so we went ahead and started her on the 400 milligrams of atazanavir. She finally started taking the medications about 30 weeks. At about 34 weeks, her viral load was 250 at follow-up. And so if you remember, her viral load had been 5,200. 4 weeks after starting therapy, her viral load is 250. A Tdap was given at the 30-week follow-up. An influenza vaccine had already been given by Women's Health when she first presented to them. So what's the job of our perinatal coordinator? Her job is to coordinate both between specialty care and high-risk OB. Also, she provides patient education, and we have found over time that the more we educate our pregnant women, the better outcomes we have. We've had our pregnant women pick up some problems that occurred in the hospital and ask for them to correct that while they were still in the hospital. We tell them what to expect. We tell them what the risk of transmission is to the infant. And we tell them about adherence. We tell them how the testing will be for the infant. We also alert the hospitals about these pregnant women so that by the time that the hospital receives them, they know what their plan should be. Um, in the past, we used to only coordinate with the hospitals regarding the OB department, but we found out that also our best allies are both social workers and infection control at the hospitals. So we send alerts to them also so that they can be aware of the patients coming in. Whitney goes out to educate private OB providers, especially on how to obtain some of the resources such as medication for the infant once the infant is born, etc. We coordinate with Healthy Start, and she ensures that testing is completed and immunizations are administered. Immunizations are recommended in pregnancy for HIV-positive women, and the two most important ones are influenza vaccine that should be given to all pregnant women during influenza season, and the Tdap. This is based on the new AICP 2013 guidelines. What this showed was that there is an increased transfer of antibodies of immunity from the mother to the infant if a Tdap is given during the third trimester of pregnancy instead of giving it the way it had been recommended at the time that the woman has already had the baby. To me, in HIV-positive women, this is even more important because we are not going to tell the mother to breastfeed. We're going to contraindicate that. Therefore, the baby is not receiving maternal pertussis antibodies during those first 2 months that are so critical because they have not received a vaccine. So we make sure that all our women get a Tdap between 27 and 36 weeks. And this is regardless of what their past immunization status is. If they were pregnant a year ago and had a Tdap during that pregnancy, they should still get one. And again, the best timing is between 27 and 36 weeks of gestation because that's when most of the antibodies are going to be transmitted to the infant and protection is going to be provided after birth. So let's get to our third patient. So this was Mrs. C, and if you remember correctly, Mrs. C was our patient who had some difficulties with adherence. She was a substance abuser, and she comes in for her initial appointment thanks to the fact that our DIS was able to pick her up and bring her in. Her CD4 count is now 11. Her viral load is 120,000, and she has not been taking her antiretroviral since her last child was born in 2012. She is now 32 weeks pregnant. We're still waiting for her genotype. If you remember correctly, she had some past resistance. Her last regimen in 2012 was Prozista boosted with ritonavir, tenofovir and emtricitabine, and raltegravir. So we decided to initiate her regimen again. Since she is already in her third trimester, we give her influenza and Tdap vaccines, and we decide to follow up 2 weeks from today. Records are sent to all area hospitals so that they may be aware that she may come in early. So what happens during labor and delivery? Now, some of the slides that I will show you were done before the new guideline changes, so I will explain some of the new guideline changes as I go. The most important part of coordinating care with the hospital is educating the hospital staff. Unfortunately, hospitals in the area have a lot of changeover, so we have to very frequently go back to re-educate hospital staff on management of our pregnant HIV-positive women. And part of the reason why education is so difficult is because a lot of what we need for HIV-positive women goes against what the current trends are in OB management. So for example, we are telling other sites are telling the hospitals that it is best not to bathe the baby immediately and give the baby to the mother so that there can be bonding, whereas in HIV-positive women, we want the babies to be bathed as soon as possible. Or there is such an emphasis on breastfeeding in maternity care, whereas we have to say, don't encourage breastfeeding, discourage it at all costs. So there's, some of it can be counterintuitive to hospital staff. We make sure that information is sent ahead of time, OB department to OB department, so our high risk sends to their OB department. But we also send a fax to infection control with the patient's name, the last CD4 count, and the last viral load. we find that this has made a big difference in especially when women may come to a different hospital than they had planned or may show up in labor, no one knows about them, and has helped us with communication. So this is one of the areas that, as I said, has been updated in the new guidelines regarding IV-AZT. The new guidelines say that if a woman's viral load is below 1,000 and she is on an antiretroviral regimen, she may not need IV-AZT. We have not made changes to our protocols at this time, and I'm working on deciding what we will be doing, to be honest, because it may be very difficult to communicate with the hospitals if a woman's viral load goes up at the last minute. So I'm still a little reluctant to make any changes in that area, but I want you to know that the guidelines have changed. Now, one of the advantages, and I like to discuss this with some of the local OBGYNs and also with some of my patients, before there was a big push of inducing HIV-positive women so that they would get those 6 hours of IV-AZT. And I think right now we don't need to push for them to sit at the hospital and get 6 hours of IV-AZT if their viral loads are really below 1,000. Cesarean section if indicated. Patients need to bring their medication to the hospital, and we make sure we discuss this with them at their visits because they need to also make sure that they have the 400 milligram atazanavir for while they're still pregnant, and then the 300 milligrams for after delivery. So going back to our third patient, she was our non-adherent woman who came in at 32 weeks gestation to see us and had a viral load of about 120,000. She came into the hospital in labor at 33 weeks. She had only been on antiretrovirals for 4 days, and she had a C-section to deliver a premature male baby who required intubation and mechanical ventilation. On the other hand, our Maltepera, this was her 6th child, presents to the hospital in precipitous labor at 37 weeks. They do not have time to give her any IV-AZT. She had rupture of membranes about 1 hour prior to delivery, and she has a baby girl who appears to be healthy. So let's talk about the care of the newborn and infant. Now, here is where things, again, get a little counterintuitive for the hospital, because this is not what the recommendation is in other settings. We recommend that there be no breastfeeding, the baby be bathed as soon as possible to remove maternal fluids, and that the baby is bathed before any needles are given, so before the vitamin K injection or the hepatitis C vaccines are given. How do we otherwise manage the newborn? We get a PCR at birth, and we've been very lucky that our hospitals have worked with us in getting a PCR at 48 hours if we think that the woman's not going to bring the baby back in at 2 weeks. So for example, for Mrs. C, our non-adherent mother, the hospital will keep the baby longer so that we can get a PCR done after 48 hours, since we're not sure that this mother will come back with her baby. We recommend starting AZT, and if the baby is term and is taking oral medication, the dosing is 4 milligrams per kilogram PO every 12 hours. Now remember I mentioned education of the mother. This is one of the areas where I make sure that the mother knows the dosing even when she sees us at the clinic. In the past we've had someone discharged on 10 times the dose of medication that they should have been discharged. So, and luckily that mother caught it and called us right away. So I always tell the mother the dose of AZT for a term baby that's about the usual weight should be somewhere around 1 milliliter twice a day. If it's anything other than 1 milliliter or around that area, you need to call us and ask about dosing. And we always educate the mother about the dosing here and also once she's at the hospital. Whitney goes out to the hospital to make sure the mothers know how to dose the AZT. We've also been able to coordinate with some of the local pharmacies. One of the area hospitals provides the AZT to the mothers and gives them a bottle with enough medicine for the 6 weeks before they go home. But some of the other hospitals did not have an outpatient pharmacy where they could do that. So we have been able to coordinate with one of the local specialty pharmacies who will drive out with a courier to bring the medicine to the hospital and provide education before the mother goes home with the baby. And we have done that with at least 3 of the area hospitals that do not have access um, to an outpatient pharmacy so they can provide the oral AZT. So going back to our cases, this is baby B. So this is the baby of the woman who had initially refused testing and was about 27 weeks pregnant by the time she presented to us. The baby's birth PCR is negative, and the hospital decided to go ahead and repeat a PCR at the time of discharge, which was about 50 hours. The AZT was delivered by the specialty pharmacy to the hospital prior to discharge with education, and follow-up was established at our clinic at 2 weeks old, both for the baby and the mother. The baby was also to follow up with a pediatrician in 1 to 2 days. Now baby C, on the other hand, this was our premature baby with a substance abusing mother. Baby C was started on IV AZT. They were not able to use the oral route, so they did not initiate other medications immediately. At about 24 hours after discussion with us, and once the baby was able to tolerate through the parental route, the baby was given nevirapine through an NG tube and lamivudine through an NG tube. A birth PCR was negative, and the second PCR was obtained at 48 hours and was also negative. The baby was sent to a foster home for when the baby was about 4 weeks old. So what happens with these very high-risk children? We do not have a pediatric infectious disease available in Polk County hospitals, so we communicate with the infectious disease doctors at all children's and at USF for advice when it's needed, but most of the time the hospitals call me. The current hospital protocols include nevirapine to be dosed at 0, 48 hours, and 96 hours after the second dose. I believe that with the evidence that is out there regarding the baby that became seronegative, we may have to, or who became, we think may have achieved a cure, let's call it that way, we may consider changing the protocols to include adding lamivudine. Currently, it's sort of discussion between the pediatric providers in the hospital and ourselves, and sometimes the infectious disease doctors over at USF. So baby B was seen at 2 weeks old, 6 weeks old, and 4 months old. Her birth PCR, 48-hour PCR, 6-week PCR, and 4-month PCRs were all negative. Oral AZT was stopped at 6 weeks old. She's followed routinely by her pediatrician. And we plan on performing an ELISA Western blot at about 18 weeks old. Now I know that a lot of sites do no longer perform ELISA Western blots, and it is no longer required. We continue to perform them because we find that, for one reason, it helps us bring the baby back at 18 months old and therefore also bring the mom back if she's dropped out of care. But also it does help the mothers have the closure that all testing has been completed and antibodies are negative. And also in case that at any time later on there was a question about an exposure of the infant, we could say that their ELISA and Western blot had been completed and were negative. And we always discuss pre-mastication of food at every visit, as well as discussing no breastfeeding at every visit. So pre-mastication of food, there's some cases documented both here in Florida and elsewhere that have shown that there was transmission of HIV to children thought to be because of pre-masticated food. It seems that this is a habit that is very common among some groups of individuals, especially here in Florida. We need to make sure that providers should ensure that their parents, especially HIV-positive parents, but also caregivers, know that there is a risk of transmission and discuss safer feeding options. Now, something we need to remember is it's the caregiver, the parent, and there's been occasions where transmission has occurred through another caregiver, such as an aunt. So it's important to discuss with all our parents that that pre-mastication should not occur. So going back to baby C, this was our premature baby. Baby C completed oral AZT at 6 weeks old. The nevirapine was stopped after the third dose, and the imibudine was stopped after 2 weeks. The PCR at 6 weeks and 4 months was negative, and the baby was seen for follow-up with the foster parents at 6 weeks and 4 months. He is also followed routinely by his pediatrician, and he's scheduled to have an ELISA around 18 months old. So as I said, one of our initial goals of this program was to keep mothers in care. It seems that looking back at our data, we're most successful at keeping moms in care during their first 4 months. Looking back at what we have achieved since we changed the clinic to this setting, if the child is less than 6 months old, it looks like 60% of women remain in care. But once the children reach 6 months old, only 30% of our mothers have remained in care. And that is extremely low compared to our other patients, our non-mother patients, who usually stay in care at much higher rates. I think the barriers are still the same, and the denial, mental health problems, and substance abuse are still the most important. But it seems that also our women who were diagnosed HIV positive at the beginning of pregnancy tend to have lower rates of staying in care than women who were already HIV positive and already in care or not. So the women who were going to remain in care, the women who were adherent from the beginning, continue to stay in care, but those who had substance abuse problems, those who are in denial, drop out as soon as the baby is no longer being seen by us. And those seem to be the same women that we can't track down to get ELISA Western blots on, even though we try to use the ELISA Western blot as a way to bring them back into care. So Mrs. B was our mother of 6. She came in for follow-up with her child at 2 weeks postpartum and then 4 months postpartum. We gave her a follow-up appointment 3 months after that. Now she would not be coming in with her child at that visit. She can bring the child, but the child will not be seen, and she missed her appointment. After that, we started a protocol for bringing people back into care, and we're hoping that maybe we can bring her back to care at the time of her child's ELISA, since that seems to be another time that women reach out to us and come back. Mrs. C, on the other hand, again fell away. She consented to a tubal ligation at the time of her cesarean, and the foster parents mentioned to us that she is back to using drugs and she has made no contact with the child in the past 2 months. And so to summarize, the care of an HIV-positive woman and her child is a very complex care that requires a multi-specialty approach and requires a very interdisciplinary approach. We have been very lucky in that we have so many services provided in one site, but that may not always be the case, and that's where we rely heavily on perinatal coordinators to help us navigate the system and help these women navigate the system. We have found that by coordinating the care between the mothers and the infants, we are better able to keep the mothers in care during the time that the infants are being followed by us, but unfortunately that does not continue to occur once the infant is done with testing, and we need to find a better approach to keeping mothers in care. Now I'm going to open the floor to any questions, and I see that we have one already, and this question says, how do you provide preconceptional counseling? We follow women during the time that they are not yet pregnant, and we also may follow men during the time that they're thinking of their spouses or partners becoming pregnant. We also, if they are not seeking pregnancy at this point, we make sure that we provide birth control or refer them to one of the women's health clinics at the health department for birth control. Now, this has been an interesting experience to us because in the past, the thought was that the HIV provider should not provide birth control and should refer everyone out. And after a lot of fighting, we have been able to decide that we will provide birth control at our clinic. I think that has decreased pregnancies for a lot of reasons. One because the women would just not follow up at Women's Health, but also because birth control has become very complex in regards to drug interactions with some of the antiretrovirals. So by doing this, we can recommend the appropriate birth control for women based on their antiretroviral regimen. And there is a nice table on the new guidelines that shows recommendations, newly updated recommendations regarding birth control with certain antiretrovirals, and it's got some interesting information. For example, I did not know until I read the new guidelines that you do not need to change birth control if using cobicistat and elvitegravir, so Stribild, where I had always thought that there would be a large drug interaction between those. Now, if the couple is discordant, it's a little more complicated than that. So other than having the discussion that we already had about the woman's health, we're also going to discuss ways that they can safely become pregnant without putting the other partner at risk. So if the woman is the one who's HIV positive, then the safest method is to recommend self-insemination with the partner's sperm, or if they can afford it, artificial insemination. Now, if the male is positive, the best approach would be to achieve pregnancy through a sperm donor or to obtain sperm washing if possible. Now, obviously we live in a county where there's not a lot of money for this type of intervention, and most of my patients find that impossible. So then I have in the past had discussions with my patients regarding pre-exposure prophylaxis for the HIV negative woman. And there's two options. The pre-exposure prophylaxis can be used only during the time that pregnancy is being sought, or based on the new guidelines, the pre-exposure prophylaxis can be continued throughout pregnancy. And this would depend on if we consider the risk for the woman to acquire HIV during pregnancy if her partner is positive being high. Now, that woman who's negative needs to be tested very frequently, and there needs to be a lot of consideration to performing a rapid test at the time of delivery, because she could become HIV positive during pregnancy or at the time of delivery, and there would be a very high risk of transmitting to the infant if that were the scenario. Now, Millie, do you have any other questions you want to share?
I see that we have a question about the kinds of education that the perinatal coordinator provides, and I think that the materials you use are all materials that come from the perinatal HIV prevention program. Is that right, Dr. Chiriboga?
We use materials from the perinatal prevention program, but also at some point we had a previous perinatal coordinator who again did not come from a nursing background, and we created some cheat sheets which list what education needs to be performed at what time during the pregnancy. So our cheat sheet, for example, during the first trimester, she will discuss things related to general transmission and adherence to antiretrovirals. Then in the second trimester, she goes more into what to expect during pregnancy, during the time of delivery, and during the third trimester, and what the infant's testing is going to be. And then we reiterate everything in the third trimester in preparation for the baby to be born. This was created between one of our nurses and our high-risk OB supervisor, as well as this previous perinatal coordinator. But all materials that are given to the women are created by the perinatal prevention program.
Now, Dr. Chiriboga, there are two more questions. One is about limited places of care regarding HIV-positive children, and are there any in Polk County? You want to address that?
Sure. There is a place for HIV-positive children to receive HIV care in Polk County. They receive their care through the USF, through the Children's Medical Services program at the CMS building. The physicians come here only every other month, which means that a child who needs more complex care than that is not able to receive all their care in Polk County. So once the children are in care through their program, a lot of times they will have to travel to Tampa for some of their initial care. But once the children are stable and only need to be seen every 3 to 6 months, they can be seen in Polk County at Children's Medical Services.
And that's at the All Children's specialty clinic that's at the All Children's site?
Yes, exactly.
Now, someone else has asked about IV-AZT. Would you go over again the changes that have occurred in the perinatal guidelines and the constraints, please?
Okay, sure. So as you remember, the last guidelines that were published had said that if a woman's CD4 count was above, I believe, 350 or 500, I'm not sure, and I think it was 450, and the viral load was undetectable at the time of delivery, or two weeks prior to delivery, they did not need to receive IV-AZT. What the current guidelines say, the ones that were just published, they say that if a woman has a viral load of less than 1,000 and is taking their antiretrovirals appropriately at the time of delivery, has not had any changes in the way that they're taking their antiretrovirals at the time that they come to the hospital, and their viral load was undetectable, was less than 1,000, so the same cutoff as cesarean section, they do not need to be on IV-AZT. So the bottom line would be, based on the new guidelines, any woman who was going to have a vaginal delivery because of their HIV, they didn't need a cesarean because of their HIV, would be able to not receive IV-AZT. The constraint that I find is that I think towards the end of pregnancy, especially if a woman's been in labor for a few days, there may be changes to the way that they take their antiretrovirals. Especially, towards the very end of pregnancy, women get uncomfortable. They might have so much reflux that they might not take their medicine. So there might be a change at the end of their pregnancy that leads to a higher viral load, and that would be my only concern. Now, on the other hand, as I mentioned, it does make it easier in that if you have a woman that comes in labor, you don't need to, and they're about to deliver the baby, you don't need to worry about putting that IV-AZT. Before, we were very worried about these women that had not received IV-AZT because they came in labor and it was too late. And that led to a lot of women being induced or being brought into the hospital before their due date so that they could get those 6 hours of IV-AZT in. And now we know that that's not necessary. As I said, I'm still considering what we're going to recommend at our hospitals, but I think that my recommendation is going to be that once the woman is in the hospital in labor, they go ahead and start the IV-AZT, but that they avoid bringing the woman in specifically to get IV-AZT. And some of our women are very concerned about the IV-AZT. There are some that worry that that will lead to disclosure of their status. So I think a lot of this is going to have to also be a discussion with the woman regarding if we can send a recommendation for no IV-AZT, therefore limiting the risk of exposure, of disclosure.
And probably the biggest concern is that too often the prenatals that they're making these decisions on, the viral loads are not recent viral loads, and they need to probably be less than 4 weeks old. But
yes, definitely. And something that has helped us achieve this is that we make sure that we get a viral load at about 32 weeks of pregnancy, so that if a woman comes into the hospital in labor somewhere around 36 weeks, they have a viral load. But then we repeat one around 37 to 38 weeks, because we know that most of our women will be delivered somewhere between 39 and 40 weeks. So then we have a more recent viral load, but still we get one earlier on, just so that we can be sure that if they go into the hospital in labor, they have something recent to base themselves on.
Good. Now, part of that question includes, could they not draw a sample at that time? And we know that that test takes time for the results to come back. And that it really isn't, it isn't a desirable way to determine the most current viral load, because it does take time and it's expensive.
A viral load in the best scenario takes about 3 to 5 days to complete, and with some labs can take more than 2 weeks. So that would really not be possible to obtain. There's not a rapid viral load yet in the market.
The Florida Caribbean AIDS Education and Training Center's mission is to ensure that physicians, nurses, nurse practitioners, physician assistants, dentists, pharmacists, case managers, and other healthcare professionals in Florida, Puerto Rico, and the U.S. Virgin Islands receive state-of-the-art information, training, and consultation on the prevention, chronic disease management, and treatment of HIV and AIDS. Funding is provided by the HIV/AIDS Bureau of the Health Resources Services Administration, U.S. Department of Health and Human Services. The Florida Caribbean AIDS Education and Training Center provides a variety of HIV/AIDS education, training, consultation, and resources. Visit our website, www.fcaetc.org, to learn more. Stay in touch with us by joining our mailing and email list. You will receive notices about upcoming educational opportunities as well as new and updated HIV/AIDS resources. You may also sign up to receive our HIV CareLink newsletter. Visit our website, fcaetc.org, and click on Join Our Mailing and Email List at the top of the homepage. Be sure to also connect with us on Facebook, Twitter, LinkedIn, and YouTube. The Florida Caribbean AETC provides consultation services to clinicians in Florida, Puerto Rico, and the U.S. Virgin Islands. If you have questions related to the content of this program or would like consultation on the diagnosis, prevention, and treatment of HIV/AIDS and related conditions, we would love to hear from you. We also offer consultation on the interpretation of resistance test results. Visit www.fcaetc.org/consultation to ask your question today. The Florida Caribbean AIDS Education and Training Center provides pocket-sized treatment guideline resources that detail the federally approved HIV/AIDS medical practice guidelines, such as the adult antiretroviral therapy, hepatitis, pediatric antiretroviral therapy, adult opportunistic infections, tuberculosis, and pre-exposure prophylaxis, non-occupational post-exposure prophylaxis, and occupational PEP. In addition, we have summarized common practices for the post-exposure prophylaxis in pediatrics adolescents. We have also developed resources that provide an overview for treatment of sexually transmitted diseases in HIV-infected patients and therapeutic agents for oral manifestations. Visit our website to download or request copies of these resources. The Florida Caribbean AIDS Education and Training Center provides web-based educational opportunities to increase the knowledge and skills of HIV healthcare providers. Live and on-demand options are available. Visit www.fcaetc.org/education for more information. Florida Caribbean AIDS Education and Training Center, Project ECHO, provides a web-based didactic presentation on a current HIV treatment issue based upon current Department of Health and Human Services and other accepted treatment guidelines. Project ECHO also provides an opportunity to discuss case presentations submitted by participants and an opportunity to network with both your peers and HIV experts. All members of care and treatment teams, including case managers, are welcome to participate. Information discussed is targeted at providers with basic or intermediate HIV/AIDS treatment experience. Choose from 4 session types. Visit www.fcaetc.org/echo to view upcoming sessions and to register. If you're located outside of our region, the Clinician Consultation Center provides consultation services via the phone numbers listed here. Or you may also visit www.nccc.org www.ucsf.edu for more information. To locate the AETC in your region, visit www.aidsetc.org.